Good morning, everyone. Welcome to our breakout session on COVID-19 vaccination and vaccine hesitancy. I'm Erin Lipp at the College of Public Health, and we're really happy to have you join us at this year's State of the Public Health Conference, along with our presenters, Glen Nowak, and who'll be joined by Michael Cacciatore. If you need assistance during the session, please direct your message to Sandy Stibbets using the Zoom chat feature. I'll now turn it over to our presenters to start the session, and thank you.
Well, thanks, Erin. This is Glen Nowak, and just a couple of clarifications. So Mike won't be joining me this morning. We had hoped to have some data for national survey, but we didn't get our data in time. So I'm going to take a somewhat different approach. I'll still have data, but I'm also trying to structure this presentation to kind of build off what Amber was talking about in the first session, and to give you some suggestions about communications that can help you with vaccine hesitancy or to address vaccine hesitancy, and also some resources that you might not know about when it comes to this space. So if I can see. So in early December, I did a presentation for the Immunization Coalition in Washington, D.C. And it was interesting to look back at that presentation, some of the headlines that were making the news back then. And I think what you'll notice is that many of the headlines that were making news in early December are the same headlines that we're seeing today when it comes to COVID-19 vaccines. So in early December, vaccine was starting to arrive. There was recognition that people had questions and concerns related to vaccine. Among the concerns people expressed was that it was too early. How could you have vaccines this fast? There was questions about, will they work? How safe are they? Lots of interest in misinformation, disinformation, and whether that could cause people to become disinterested in vaccines. And then ultimately, there was a lot of questions in early December about, as we get vaccines, will enough people take it? And here we are in early January, and I would say that many of the headlines, as I mentioned, are the same. And we still have that question about, will enough people take these vaccines? When you talk about vaccine hesitancy and vaccine confidence and vaccine acceptance, I think it's really important to understand what those terms mean and to define those terms. Often in the literature, they go undefined, and that can make it really difficult, particularly if you're trying to develop a communications or education strategy that is designed to address those things. So what is vaccine hesitancy? Well, ultimately, vaccine hesitancy is a state of mind. It's one's willingness or reluctance to get a recommended vaccine or vaccination. Why are we concerned about vaccine hesitancy? We're concerned about vaccine hesitancy because hesitancy or reluctance can cause people to delay getting a recommended vaccine, or it can cause them to forego it altogether. Vaccine confidence is related to hesitancy, but it's not the same thing. Vaccine confidence, and I've done research myself, I've been involved in research where we have asked parents, we've asked adults about what does it mean to be confident in something like a vaccine or a recommended treatment. And oftentimes it comes down to a couple of key things. One is that many people, confidence is their faith or strength of belief that if they do something, such as receive a recommended vaccine, two things will happen. They will get a significant benefit, and there will be very little or no outcome or no likelihood of a negative outcome. Now, they often do vary in terms of what they perceive a negative outcome to be. For some people, it's the immediate actions that can happen 4 or 5 days after a vaccine. For other people, they're fearful of significant chronic adverse events. There also has to be that strong belief that the benefits of receiving a recommended vaccine or vaccination far exceed any possible risk. So that's confidence. And then acceptance is they agree to get a recommended vaccine and they get vaccinated. The relationship that's often believed to connect these three concepts is that people who are hesitant, that is, have high degree of reluctance, are going to be less confident and thus less willing to accept a vaccine, or that people who don't have much confidence are going to be hesitant and not accept the vaccine. So they are linked, and the goal is to build confidence, reduce hesitancy as a way of fostering vaccination acceptance and vaccination. I've been involved, like many others, in trying to look at the relationship between confidence and vaccination. And Here's an example of what we have found in the world of flu vaccination. This is a study I published in 2016 based on a national survey of 1,000 adults. And as you can see in the highlighted area, there's a very strong relationship between confidence in the safety of seasonal flu vaccine, confidence in the effectiveness of seasonal flu vaccine, and confidence that you would benefit from receiving the flu vaccine, and people actually getting that vaccine. And so 4 or 5s are high levels of confidence, and the people with 4s or 5s, 75% of those people said they got a flu vaccination in the last 12 months. And so that's why we're really concerned about trying to bolster and boost and foster confidence in COVID-19 vaccines. So in this presentation, my focus is primarily on providing you with insights into the state of COVID-19 vaccine acceptance, the factors that influence confidence and hesitancy, and how to approach vaccine communications and education to address hesitancy and foster acceptance. I'm going to focus on 3 domains. I'm going to talk first about some findings from 4 major surveys and reports regarding what looks like is acceptance of COVID-19 vaccine based on surveys in the last couple of months. Look at 7 suggestions regarding COVID-19 vaccine-related communications going forward. And then 5 resources that I think you may find helpful. And you probably may not be aware of all of these. I've come to know the existence of a couple of these just in the last week. But I think they're all really helpful when it comes to COVID-19 vaccine communications and education. So the landscape, what does the vaccine communications landscape? If you're doing COVID-19 vaccine communications or education or about to embark on it, what are some of the things you need to know about that landscape? Well, there's a growing body of research that appears to show pretty consistently, there's now probably about a dozen or so surveys, that about 60% of people in the United States appear to be interested, willing to get a COVID-19 vaccine. And somewhere between 20, 25%, maybe 30% are indicating right now that they're probably not likely to get a vaccine. That's not their current state of intention. One of the best sources for information on surveys is the Pew Research Center. And if you go to their website, they make their survey findings or methodologies or data publicly available. And their most recent survey, they've been tracking this for nearly 10 months now. And what they're finding is that intention to be vaccinated for COVID-19 has been going up over time, that there still are deep divides over mask wearing, and that people's comfort with activities align with their degree of concern about getting a serious case of COVID-19. So people who see COVID-19 as a serious health threat are more motivated. A number of studies, and I think this was alluded to in Amber's opening presentation, are continuing to show that there are partisan divides over COVID-19, including in the vaccine space. And those things also extend to trust in scientists and public health. The majority of Americans do say that they would get a vaccine for the coronavirus. As you can see, that was highest in May of 2020. It went down in the summer and early fall, and it's now crept back up to 60%. They looked at people who said they would not get the vaccine and asked them, would you get the vaccine if you had more information? And what they found was that, again, about half of that group said possibly, but half of that group said no. And then, as I mentioned with flu, they also found that intent to get COVID-19 vaccine rises as confidence in the research and development process increases. Some other key points from that recent report are that personal concern about getting a case of COVID-19 that would require hospitalization. If people held that belief, that was motivating when it came to them being interested in the vaccine. Those who see little personal need by this metric are closely divided over whether they would get a vaccine. Trust matters. There's been a lot of research in the vaccine confidence space that shows that trust is a key driver of confidence. Trust in the development process seems to matter based on the Pew research in terms of motivating or being correlated with people's willingness to get a COVID-19 vaccine. Personal practices when it comes to other vaccines. Not surprisingly, perhaps, those who say they get a flu shot yearly are more likely to express interest and willingness to get a COVID-19 vaccine than those who rarely or never get a flu shot. And then, as again mentioned before, partisanship, and they found a 19-point gap between the shares of Democrats and those who lean to the Democratic Party and Republicans and Republican leaners who say they would get vaccinated for the coronavirus. Another study that was done in the summer, but the results just were highlighted in early January, found that Black Americans, women, conservatives are more hesitant to trust the COVID-19 vaccine. And this was a study done by Texas A&M University with about 5,000 Americans. And they, similar to Pew, found that about a third said they did not intend to get the COVID-19 vaccine once it becomes available to them. Their top concerns were safety and effectiveness, but those concerns varied across subpopulations. Women were 71% more likely not to pursue vaccination and said they were hesitant based on safety concerns and effectiveness. Blacks were 41% more likely to not pursue vaccination and said their hesitancy stemmed from safety and effectiveness concerns, but also lack of financial resources or health insurance. And again, that's a challenge because that shouldn't be a barrier to COVID-19 vaccine because these vaccines are free. And it looks like the administration will also be covered in terms of receiving those vaccines. And then again, they found conservatism increased the odds of vaccine refusal. They had a table. Here are some of the findings specifically. And I think that a couple of things I would note here is that, again, when you look at it from this perspective, you're not seeing really high numbers. And so you're seeing that the number one reason is the vaccine won't be safe, vaccine won't be effective. Those beliefs being held by about 10 to 15%. You look at the bottom of the list, some good news, I think, is that there doesn't seem to be great reluctance if you've already had COVID-19. Rural America, Amber mentioned this in her talk, vaccine hesitancy in rural America is based on survey data, a real phenomenon. And this was a survey done by the Kaiser Family Foundation. They have a health tracking pool. Like Pew, they've been doing regular monitoring and they've been using multiple research methods to do that. What they have found is that more than a third of rural residents are hesitant to get a COVID-19 vaccine, and that places them alongside Republicans and Black adults as among the groups most wary of getting vaccinated. They found that 15% of rural residents said they would probably not get a safe and free vaccine if available, and 20% said they would definitely not get it. And only 3 in 10 rural residents said they would definitely get it, compared with 4 in 10 in urban and suburban areas. And then again, we're seeing this divide between Republicans and Democrats in terms of willingness to get a COVID-19 vaccine. They did a number of analyses, and when the results were controlled for factors such as political affiliation, hesitancy was still high or higher among rural residents than those in urban and suburban areas. Rural residents get news from different places, and so some of their survey looked at what might be useful venues or platforms to reach them. The survey showed that half of rural residents said the seriousness of the coronavirus has been greatly exaggerated in the news, compared with 27% of urban and suburban residents. 62% of rural residents said they see getting the vaccine as a personal choice versus a responsibility to help protect the health of other people. And then for rural Americans, trusted messengers, at the top of that list was their healthcare provider. And then that was followed by some government agencies and trust in state governments. So you could see a big discrepancy in terms of, the top of the list really is their healthcare provider. And then finally, another study looked at healthcare workers, and a surprising number of US healthcare workers are refusing to get the COVID-19 vaccine. That is particularly the case in healthcare workers in US nursing homes. And so as much as 80% are turning down the shot in some institutions, according to an Associated Press story. It's important to understand why healthcare workers are declining, why they're reluctant. Healthcare workers are at the top of the priority list, and so it's important that they get vaccinated. They are also going to be a group that others are going to look to in terms of whether they should get vaccinated themselves. And then finally, healthcare workers are going to provide these vaccines. So it's really important that they are confident in the safety, effectiveness, and value of COVID-19 vaccines. The COVID-19 vaccine communication landscape, that's what it looks like in terms of acceptance. There are also a number of things, and many people are probably very familiar with a bunch of other things that are happening in the COVID-19 vaccine landscape that do and will affect people's confidence, hesitancy, and acceptance. One of the things that has been cited is that America is behind in COVID-19 vaccine messaging, that there's been a late start. That is true. It's also a challenge because it's hard to do messaging when you don't know what the vaccines are going to look like, what their availability is going to be, what their safety and effectiveness profiles are. But right now, there really is a growing need for a lot more vaccine messaging, education, communications about these vaccines. The rollout matters, and it matters. It can affect, it does affect people's confidence and acceptance and hesitancy. When rollouts go well, people are more willing to get vaccinated, but we're seeing across the country that uneven supplies are causing frustration. Disorganization is causing frustration. People showing up and not being able to get vaccine is causing frustration. Many people don't understand or don't realize how complex vaccine administration and delivery is. And so you get statements in the news like this person who said, you know, we're talking about vaccinations, we're not talking about putting logistics together for something like Desert Storm. Fortunately, the reality is that logistics associated with vaccine administration are quite complicated, particularly if you're putting a system on top of a system that is already responsible for treating people, diagnosing and treating people who are ill with COVID-19 and other illnesses. There has been many who have recognized the US vaccination plan, maybe also limiting the speed of the rollout, that it's a decentralized effort, that it's easy to get vaccines to one place, such as maybe to a state, much harder to get that vaccine dispersed within the state, within communities, to healthcare facilities. And as one person noted, that if you told states their priority should be to vaccinate as many people as possible, as fast as they can, it's likely that the campaigns would have been run differently, but that's not what they were told. So there are, the overall decentralized effort is causing, again, confusion that leads to reluctance, hesitancy, and less acceptance. Not surprisingly, because we know from regularly recommended adult, adolescent, and childhood vaccines, there will be interest in safety. We know from the 2009 H1N1 pandemic that there's a lot of interest in safety-related news. People have questions and concerns about vaccine effectiveness and safety. And so this is just a smattering of some of the things, and we're going to see more of this going forward. So to date, there have been questions about, is this vaccine safe for pregnant women? Does it cause infertility? There's a lot of publicity surrounding the death of a Florida doctor who, after receiving COVID-19 vaccine, died. Deaths after vaccination are expected, not necessarily as a result, but just coincidentally, but you have to be able to assess whether that is the case or not the case. There's been a lot of stories about Bell's palsy, about severe allergic reactions, headlines that are sort of deceptive. They're true about people who got COVID after getting vaccine. That's possible, but it's not, again, the headline is literally true, but it's not the case that the vaccine gave them COVID-19. They likely were infected before they got the vaccine. If they got the vaccine, they're still susceptible, probably, particularly at the first dose, for many days, if not weeks. These are 2-dose vaccines, and so you may not be fully protected until you get both doses, and it may be 5 to 7 days after the second dose that you have full protection. So yes, people can get vaccinated and still get COVID. And so a lot of stories about that, but those all make the news. People see them, people share them, and they can foster hesitancy and reduce confidence. Hospitals thought they would see vaccine shortages, and in some places, many places, probably most places, that's probably the case. But in other hospitals, they're worried about about having to throw vaccines away. And so they're putting vaccines into arms because it's a more useful place for them. And again, when you do that, one, you do vaccinate people, protect people, but again, it takes you away from strict following the recommendation protocols. The Biden administration has announced that they are going to change the policy and shift from the current strategy of holding half the supply for booster doses and basically accelerate distribution of vaccine. Again, that will cause challenges, will change the landscape, and that can affect and probably will affect people's hesitancy and confidence levels, especially if it doesn't go well, or especially if people come back or want to come back for that second dose, and that second dose is not readily available. So thoughts and suggestions about communications related to COVID-19 vaccine going forward. And for those of you who don't know, I spent 14 years at the US Centers for Disease Control Prevention. I spent 6 years as Director of Communications for the CDC's National Immunization Program, followed by 6 years as Director of Media Relations for CDC, including during the 2009 H1N1 pandemic. And I've continued since I returned to the University of Georgia in 2013 to stay actively involved in vaccine and infectious disease-related communications. And so I'm going to draw from both the literature, best practice, and my own personal experiences in offering my thoughts and suggestions regarding COVID-19 vaccine-related communications. I think the first one is really important, and I think many people have thought this would go really easily well. And I think having gone through vaccine shortages as a communications director at the CDC and having gone through the 2009 H1N1 pandemic, what I would say is really important when you're thinking about COVID-19 vaccine communications and education, to have a different assumption. And that different assumption is that this is a more challenging landscape, a more challenging communications and education environment than we've ever experienced in vaccines. Why so? Well, first of all, there are many uncertainties regarding the initial COVID-19 vaccines, even today, as those vaccines are still, the data is still being assessed. More data is collected every single day related to safety, effectiveness, duration of protection, overall availability, local availability, demand, all those things. Uncertainties matter when it comes to communications. We know, and I showed you some of the data, that trust, credibility, and health information seeking are strongly connected with moral values and political beliefs when it comes to COVID-19 vaccines, more so probably than any other vaccine in history. There are wide variations in COVID-19 disease effects and impact, and individual perceptions and beliefs thus vary. We have 2-dose, non-interchangeable vaccines that are currently available. There are differences in federal and state priority groups, and there are also different approaches to scaling vaccination that are being used and will be used. And one of the things that's going to happen is, as more vaccine comes online, we are going to have to scale vaccination efforts, and that will result in a couple things: different approaches and severe challenges in terms of resources on public health. There's the likelihood of multiple non-interchangeable vaccines being available. There are more vaccines in the pipeline, more vaccines that are in phase 3 clinical trials in the US. And then each of these vaccines will have different requirements in terms of administration, as well as different safety and efficacy profiles, and that will cause people at some point to want to know which vaccine is best for them. So you have a more complex and dynamic vaccine and vaccination communication and education environment than we've ever experienced. And it will involve major changes in the US vaccination system as we scale. We need to recognize in our communications that, yes, people's perceptions and beliefs matter, but in many cases, those perceptions and beliefs actually are grounded in COVID-19 vaccine realities. And so the realities associated with COVID-19 vaccines do matter. It's not simply a matter of saying that, well, people have the wrong perception. Oftentimes they have the right perception because those perceptions are in fact grounded in COVID-19 vaccine realities. What do I mean by that? People's perception that one is susceptible to becoming infected with COVID-19 and likely to experience severe illness is based on age. It's based on what they know about the vaccines, based on their experiences. Same thing with beliefs regarding the processes and entities involved in vaccine development, the outcomes about the benefits from getting the vaccine, and the belief that being immunized is worth taking the steps involved in the vaccination process. When it comes to communication efforts, it's really important, and this is often an overlooked step, to think about what does success look like? What are you trying to achieve with your COVID-19 vaccination efforts and messages? 4 things that are often used as objectives are inform, educate, build confidence, and persuade. They're all different. And so if your goal is to inform, that is your ultimate intent, is to just provide information about COVID-19 vaccines and vaccinations, you are unlikely to persuade people, because that's not what you're doing. You're really basically saying, here's the information, do with it what you will. That is, information provision is often a major part of what we do in the vaccine world. But if we're trying to get acceptance, we often need to do more. The next step we often go to is educate, which is to provide people with more, try to increase their knowledge and understanding of the vaccines and vaccination and why they work, why they will protect you, how they will protect you. We're doing that often to build confidence, to build trust. And then ultimately, if our goal is to convince people who are hesitant to get vaccinated, that's going to take typically more than just information and education. It's going to take influential people they trust, endorsing, providing testimonials. Persuasion is the hardest thing to do. And a lot of times, we are not as successful or as quickly successful as we would like to be. And we often find it takes a lot more persistence and effort than we imagine. We know that there are core risk and health communications principles that have been used in the world of childhood, adolescent, and adult vaccination. We need to use them here. And they include things like tailoring messages to patient concerns and questions in life situation, expressing empathy and understanding, guiding expectations, highlighting the individual benefits associated with the vaccination recommendation, acknowledging individual risks. A lot of times, vaccine communications comes down to how well the provider recognizes and treats a person as an individual, and because many people are reluctant, want to see themselves as unique and are looking for a personalized assessment and a personalized recommendation. We know that it's important to use words and language that are understandable and culturally appropriate. It often helps to define keywords and ideas even when you think it's not necessary. We use terms in public health and science like safe, effective, side effects, adverse event, and we often assume that the person we're talking to has the same definition that we do. And then providing helpful framing and context, foreshadowing possibilities and outcomes, all those things we have learned from experience help and matter. What does that look like? Well, here's just a news story that happened in November 12th, and I think it highlights many of those principles. So for instance, the headline shows you what helpful framing and context looks like. It's acknowledging that COVID-19 vaccine may have unpleasant side effects, but that means it's working. Foreshadowing possibilities. You have a senior Pfizer executive saying that the effects from this vaccine appear to be comparable to those of standard adult vaccines, but perhaps worse than those of the company's pneumococcal vaccine or flu shots. Giving helpful context and guiding expectations. So a frame of reference is the 2-dose Shingrix vaccine, which protects older adults against the virus that causes painful shingles, and points out that, again, Prevnar and common flu shots can cause injection site pain, aches, and fevers. More helpful framing. There's evidence that suggests that if you frame pain as a proxy of effectiveness, it's helpful. If it's hurting a little, it's working. You want to tailor your information to the patient's life situation. So one of the concerns that healthcare workers have is that they may feel sick days after and be not able to work if they are sick. And so another part of fostering vaccine acceptance is addressing and removing barriers. So it's not just about communications and it's about providing incentives, removing barriers. And this pointed out that, one possibility would be, using paid leave after vaccination as a way to incentivize healthcare workers to get vaccinated. I think it's important, even though influenza and COVID-19 are qualitatively different, I think there's a lot of things that we learn from influenza vaccination hesitancy and declination that actually are going to apply when it comes to COVID-19 vaccine. We are going to be faced with many people, particularly younger adults, who are going to perceive and believe COVID-19 is a manageable illness. They perceive flu as a manageable illness, and that causes them not to be interested in flu vaccination. We are going to be faced with many people who don't know or don't believe that COVID-19 vaccination recommendations apply to people like them, or that they need protection from COVID-19. We are going to see people who believe that other measures are equally or more effective than COVID-19 vaccination, such as one's lifestyle, hand washing, diet, vitamins, avoiding people who are sick. We see that with flu. We should expect to see that with COVID-19 vaccination. We should expect that many people may perceive or believe that COVID-19 vaccines are not very effective, and or that unless duration is very long, they are not worth getting. We see that with flu. And then believing that COVID-19 vaccine would cause undesired effects. So all those things from flu that we have to deal with, we need to be ready to deal with them in the COVID-19 world. We should look for, develop, utilize, and make visible COVID-19 vaccine and vaccination communication resources, advice, and examples. Obviously, the CDC is a great resource. They've got updated information about how to talk to patients about COVID-19, how to hold those conversations, what those conversations should look like. And this website and the resources and advice are being regularly updated. It's important for us as communications people and educators and those involved in COVID-19 vaccine to recognize and foreshadow the fact that COVID-19 vaccine information will be evolving and changing in the weeks and months ahead. As Paul Offit has pointed out, when you look at the data, when we have more data, we'll be able to do things such as more accurately define what groups of people are most likely to have side effects, what the real efficacy of these vaccines is, how long duration of protection lasts. There's a lot of things that we are learning more about every day, and we will continue to learn. And then in addition to the vaccine safety and effectiveness data, we also know that we're going to have information about who should get vaccinated, number of doses available, how you can get vaccinated. That too will be evolving and changing in the weeks and months ahead. So letting people know about that and why those changes are taking place is important. So in sum, if we're going to reduce vaccination hesitancy, build confidence, particularly for these vaccines, we need healthcare providers to be confident in the safety, effectiveness, and benefits of COVID-19 vaccine, including because they need to effectively communicate that to patients and to the public. We need those who are involved in COVID-19 vaccination education and advocacy to acknowledge and address concerns and reluctance, to create high COVID-19 vaccine and vaccination recommendation understanding among healthcare programs, public health providers, healthcare providers, and immunization coalitions. So those involved need to put a high priority on fostering better understanding. We need to have and set realistic expectations regarding COVID-19 vaccines and vaccination. A large part of our efforts really need at this point to be focused on steadily building confidence and acceptance over time. Yes, there's a lot of urgency. There's a need to achieve as high of vaccination coverage rates as possible, as soon as possible. But the current reality is we don't have the vaccine supply to really achieve that. And if we don't do that first part, which is build confidence and acceptance, we are going to have a hard time achieving the latter, which is high, widespread, across the broad demand. We need to temper expectations regarding whether and how fast immunity, community immunity can be achieved with these new vaccines. There still are questions about these vaccines. We have good data about these vaccines' ability to prevent symptoms and illness. We have far less data about their ability to impede transmission. We expect to have that, but we currently don't have that. And then we need to place priority on building trust and confidence through open, continuous, frank communications on vaccine effectiveness, safety, and benefits. And so for the last thing I want to point out is, it's now I've got here five vaccine-related education and communication resources that I think you may find helpful when it comes to addressing hesitancy, building confidence, and doing communications. The Ad Council. So the Ad Council is working with the CDC Foundation and others to do two things. One is to work on how to help healthcare providers better understand and answer common questions about COVID-19 vaccination, and they have resources for doing that. They are also designing and implementing a $50 million campaign, and that campaign is going to have multiple activities. Part of it is going to be providing healthcare providers with information to share with patients who may be skeptical about the vaccine. Part of it is going to be a national public service announcements encouraging COVID-19 vaccinations. Those public service announcements are likely to become more visible as more vaccine becomes available and widely distributed. And then they are also working to specifically reach communities of color that have been hardest hit by the pandemic. And they actually have a sub-website and resources targeted to that group and to people who serve that group. So the Ad Council is a resource that I would highly recommend looking at. Another really in-depth resource is from the Institute of Public Relations. They have developed a website, and again, all these things are publicly available. You have to be a member of the Institute for Public Relations. This is what their menu page looks like. They've got various topics, and as you see toward the bottom in red, there's this new Vaccine Communications Resource Center. If you go to that Vaccine Communications Resource Center, you see this, which is information that you can get on topics like reasons behind vaccine hesitancy, misinformation, disinformation, vaccine communication strategies. They also have made available a communicator's guide to COVID-19 vaccination. And again, this is free. It draws upon research theories, models, and recommendations that communicators should know. And this is what the table of contents looks like. It runs the gamut from vaccine hesitancy and confidence to understanding audiences to guidelines and strategy recommendations for communications. The De Beaumont Foundation similarly has really great resources to do COVID-19 vaccine communications. They range from a publication that again is downloadable to a one-page, what they're calling the communications cheat sheet on communications tips, which words to use and which words to use less. They also have a PowerPoint presentation that you can download that gets into words that work in COVID-19 communications. Their recommendations are based on a lot of research that they've been doing, including some recent surveys. The Immunization Action Coalition, which receives some of its funding from the CDC, has got wonderful resources, very comprehensive resources on COVID-19 vaccines, from patient education materials to CDC materials on vaccine storage and handling to webinars on vaccines with people from CDC. So immunize.org is the website. I would highly recommend this resource. And then the final one came out just recently, an article in the New England Journal of Medicine called Beyond Politics, Promoting COVID-19 Vaccination in the United States. This is like a 6-page article with 3 really good tables. These are just a snippet of those tables. Table 1 has got a list of specific strategies for promoting COVID-19 vaccination. Not only do they give you the strategy, they describe what the action is, and they give you simple sample tactics of how you would operationalize that strategy. They also have a table with key actions for a host of different players in various healthcare roles, including state and county health agencies. And as you can see, for state and county health agencies, they provide a list of 11 key actions. So I would highly recommend taking a look at this article. It's a great source of communications advice. And with that, I thank you and happy to answer any questions. I guess I need to. Erin, would you mind? Are there any questions in the chat?
Yeah, I can share those. So we've got the first question is, how come there are 2 different vaccines? What's the difference between the Pfizer and the Moderna COVID-19 vaccines? And how is it determined who receives which vaccine?
So I'm not a vaccinologist, and so I'm going to answer this from the communications perspective. So there are two vaccines currently available. They're both messenger RNA vaccines, so they're both using the same platform. One of the key differences are one of the vaccines, the Pfizer vaccine. They're both 2-dose vaccines. One of the differences is the administration period, and so the Pfizer vaccine, the second dose is recommended to be received 3 weeks after the first dose. The Moderna vaccine, it's 4 weeks after the first dose. There are different storage and handling requirements. The Pfizer vaccine has to be stored at really cold temperatures, much colder than the Moderna vaccine. And so that makes a difference in terms of how those two vaccines are being distributed across the country. The Pfizer vaccine is being distributed by Pfizer, and it's being shipped in storage containers that have 975 doses in them. The vaccine, as I understand it, there's 10 doses per vial. Once a vial is open, you've got about 6 hours to use the vaccine in that vial. And so one of the challenges is with the Pfizer, based on its packaging, is that it's a vaccine that really has to go to places that are going to be able to vaccinate literally thousands of people per day. Much less useful to be sent to a rural facility where you may have 100 people, but you now have 975 doses that have to be used. And so the Moderna vaccine is much more flexible in terms of its packaging and distribution. And so and then what vaccine goes where? Most places are going to get one or the other. They're not going to get both. And again, it's the idea is that will be the most efficient way, and the logistics are being handled at the top level by the Department of Defense. And then once they hand it off to state and local health departments, from that point, it's distributed further. But most people, it's not envisioned. It's envisioned that it'll be quite a while before a facility would have more than one type of the vaccine. For the time being, it will have one.
All right, thank you. So the next question is, how long do you think it will take for the ad councils, PSAs, and other materials to be produced? They are clearly needed.
I believe the ad council has already produced some materials. They are working on trying to get materials out by the end of January and early February. I know that the materials, for instance, that are targeting Black communities are already available. If you go to their website, you can see those materials. Their plan is to, I think, the other group that's doing a major effort is the U.S. Department of Health and Human Services. And so the U.S. Department of Health and Human Services has a large contract with the communications firm called Forrest Marsh. And Forrest Marsh is also developing materials. They're working with HHS agencies, Food and Drug Administration, CDC, again, with a campaign timeframe that is expands over 2021, with more materials becoming more visible as vaccine availability increases.
All right, next question. So the vaccine rollout in Georgia seems to be hindered by one major issue. The demand is outpacing supply. What's the right message for the public in this case, and who should deliver that message?
Well, I think with demand outpacing supply, the key message is going to be empathy and understanding first, that to recognize that is the case, that you are as frustrated as the people who want vaccine, that patience is the key. And I think the governor has put patience as at the forefront of his messaging, because that really is what is needed at this point. I think we need to understand that probably throughout this process, we are going to see stories about mismatch between supply and demand. It is hard to get supply and demand to perfectly align. We know that from flu vaccination efforts, right? That at the beginning of the flu vaccination season, lots of places have lots of supply, and getting it, so the supply often at that point may exceed demand. As we get toward November and December, places that have been really successful in vaccinating are going to have perhaps less supply and may still have high demand. So I guess we have to also continually remind people that we're working to make sure that we have enough vaccine to meet the demands of all those who want it. But they have to be patient. And the good news is, we're getting more vaccine every day. I mean, that's the other part of the message, is to remind people that more vaccine is becoming available every single day.
All right, so there's a question about how much drag on the system, meaning health communication regarding COVID, is caused by misinformation versus a lack of information versus just apathy.
it's really hard to disentangle those things. Misinformation is often in the eye of the beholder, and a lot of misinformation is not so much factually inaccurate. It's lacking context. It's misleading. It's something that is true, but it's like, I guess a good example would be, as I mentioned in my presentation, the headlines I saw that says, person got COVID after vaccination. That is literally true. They did, but it's also misleading because there's many reasons that could happen. Apathy, I think, is probably the biggest challenge, because the challenge, misinformation gets a lot of attention because it's easy to document. We can look at Twitter and we can see its presence. We can look at other social media and see its presence. But I think what we've learned from influenza vaccination is our challenge is going to be people who don't believe that they are susceptible to severe illness from COVID-19. And as a result, they're going to be less motivated or unwilling to get vaccinated. So I think I would put apathy and denial at the top of the list. And that typically is the biggest challenge in a lot of what we're doing in health, is to overcome denial and apathy and to motivate people to get vaccinated.
All right, thank you. In your opinion, what is the best way to communicate to people who point to the few news stories of adverse side effects as a reason not to get the vaccine?
Well, I think the problem with adverse side effects is, I guess first of all, it's two things. One is to find out what they're really concerned about. Are they concerned about the fact that they may feel crummy 3 or 4 days after vaccination? They may have a sore arm. And again, the messaging there is really to persuade people that those outcomes are far better than getting a severe case of COVID. I think the other thing that we often don't highlight enough in the world of vaccination is that one of the reasons vaccines are so important is that we often don't have good ways to cure or treat the illness. And so the best thing to do is prevent the illness from happening in the first place. That it's also true that avoiding a vaccine, the other thing to keep in mind is that that's not a risk-free decision either. And most people would like to believe that if I choose not to get a vaccine, well, I've now made a risk-free decision. No, you just simply are going to assume a different set of risks. You're going to assume the risk of contracting the illness, being infected, and you're going to make the assumption that should that happen, you are not going to become severely ill. And then highlighting the fact that the vaccine is a far better alternative. It's a safer option than running the risk of becoming infected and running the risk of getting severely ill. And again, reminding people that if you get severely ill, we are not at a place right now where we have treatments that we know will work for everybody. A lot of these treatments right now we're finding work sometimes for some people. We don't know which people and why in advance. And so you're taking a significant risk, particularly if you have underlying conditions or you're 65 and older.
So the next question was about vaccine trials and then rollout for children. Do you have any idea on the expectations for kids who are under the age of 12, what parents can expect?
Well, I think for children under the age of 12, we're probably a long way away from that. The vaccine companies right now, Pfizer and Moderna have both announced that they are going to be doing clinical trials with these vaccines for children. Now, one of the other differences in terms of these vaccines is that the Advisory Committee for Immunization Practices at the CDC said that the Pfizer vaccine could be used for people 16 years old and older. So 16 and 17-year-olds can get the Pfizer vaccine. For the Moderna vaccine, it's 18 and older. Both of those companies are initially going to be looking at older teenagers in their clinical trials, people who are 13 and older. And so right now that's going to be the focus. And so it's not expected that 12 and under will be a group that perhaps I don't foresee them being part of the immunization efforts for at least the next year. I think the next step in expansion will be to 14, 15, 16-year-olds and working the way down.
All right, so here's a bigger question. This is referred to as the elephant in the room. Many public health professionals have been hesitant to get vaccinated. The questioner, Ebony Haynes, has heard many express concerns about how much we still do not know about the vaccine's long-term effects. With other vaccinations, there's been a long time to study the longer-term effects. How do you address public health professionals who have these concerns?
Well, I think those concerns are clearly legitimate. We don't have answers to all of these things. It gets back to, for some people, they are going to take a wait and see attitude. I think right now, a couple of things to consider is that since the demand exceeds supply, I think we have the ability that if somebody says no, you can turn to somebody else who says who really wants it and vaccinate those people. I think we then need to work with the healthcare workers who are saying they're reluctant or want to adopt a wait and see attitude to learn more about what are they waiting to see, right? What would they like to see that will make them more confident? At what point will they have greater confidence and be more willing to consider getting vaccinated? So I think we need to acknowledge that it's a legitimate thing to do, to say that, I have doubts or I want more information about the safety and effectiveness. The good news is that data is being collected every single day, and we are learning more about that every single day. So hopefully we will be at that point where we've got enough information to address their specific questions and concerns. But then we also need to understand what are their specific questions and concerns so that we are collecting the kind of information that will help them make the decision to get vaccinated.
So I've been told we have time for one more question before the break, so I'll go ahead and ask this last one from Jose Cordero. We have a large population of Latinx in Georgia. Are there specific approaches that should be considered with this population beyond messaging in Spanish?
So I didn't get the first part of that question. So,
oh, sorry. There's a large population of Latinx in Georgia. So what are the specific approaches that should be considered with this population that goes beyond messaging in Spanish?
Well, I think clearly working with the communities is essential. I mean, one of the things that I learned in the world of immunization at CDC was we worked a lot with immunization coalitions and organizations that worked with different groups and different subpopulations. And I think working with them to help them in terms of their education efforts, their outreach efforts, and then probably the most important thing is also working with them as a feedback to learn what do we need to do? What will help? How can we do things better? I think that's the other part of communications is to understand that effective communications is not just me talking to others, it's me listening to those who are concerned and who are working with communities so that we can come up with better ways to address their concerns and help them accomplish what needs to be accomplished, which is the more people who are vaccinated against COVID-19, the better.
Glenn, thank you so much for this session and for answering the questions. This has been really, really informative. And I know this is an issue on a lot of our minds right now. So I'd like to thank everybody for participating in this breakout. And I think we're all going to be taken back to the main session now for the rest of the program. Thank you.
Thank you.